Dr. A.V. Srinivasan is the president, Indian Academy of Neurology.
So I'm the former president of
Indian Academy of Neurology, and emeritus professor from the Tamil Nadu Dr. MGR Medical University, and adjunct professor and IIT Chennai. Former head Institute of Neurology, Madras Medical College. Is over to you, Dr. Srinivasan, to give the update. As such, we know the corona infection is a new virus, and there are no clear neurological manifestation we know of, except very few reports of some kind of encephalitis. So over to you now to give an update from neurological perspective. Thank you.
Yeah, thank you very much. In fact, it's lovely to join you all. And neurology, as usual, comes, we always say the decade of the brain started in 1900 to 2000. So all the discoveries have been made from the other systems. So with regard to neurology, the seven, I always call it 6 senses. We are in the process of perception sense, that is observation. The second is, we are now getting into recording sense. And third, all of us are using our common sense to get the best clinical sense in the neurology and corona. Once you do that, then you will be able to give an excellent therapeutic sense, which requires a definite research sense, so that we'll now see how corona, we'll have the different aspects of how often coronavirus featured by the neurological symptoms, and then any specific neurological complication that may occur with COVID-19, and how can COVID-19 interfere with the immune modulating therapies, the impact of COVID-19 on neurology practice, and the recommendations for prevention. This gives you the overall view of what is happening in the world today. And you will, next slide. In regard to the most important point in the infectivity, compared to all the other coronavirus, we find the COVID-19 has got a very, very high infectivity. Compared to the population at large, it has still got the low mortality. The number decides as if it's very high. People need not worry. 80 to 85% of the people come out of this infection. The other coronaviruses like SARS and MERS, it has got a low infectivity, but it had higher mortality. I would like to go to the next slide, which it will give you an ever-evolving dynamic scenario. The neurologists are dealing with COVID.
The first case was diagnosed in Thailand after China, and then my Singapore counterpart said that I hope we are not seeing SARS again. And at that time, I asked him that, in case it is a SARS-like illness, what is the Singapore model? And they said,
the symptoms for the neurological manifestation to look for is early morning confusion, loss of taste and smell, breathlessness while pressing the chest, and fever. And in a white-skinned people, you can see the bluish discolorations of lips. Next slide. Next slide.
Yeah.
How often the coronavirus is featured by neurological components based on the and with the existing experience of COVID-19, the good news is that neurology is not the focus. The condition is predominantly pulmonary. However, in both the cases, SARS and MERS, we have seen substantial neurological complications that may expect the same in this case as well. The indirect neurological complications that include parents with COVID-19 are at a risk of indirect neurological complications, major and multiple organ system dysfunction and failure, and you will find disseminated intravascular coagulations and sepsis. There have been several early reports suggesting that a subset of COVID-19 patients are at the risk of vascular events such as ischemic and hemorrhagic strokes. However, further follow-up and research is needed in this case. As per a recent publication, in hospitalized COVID-19 patients, 60% had milder infections while 40% had severe infection. The neurological complications occurred more frequently in this group of patients with more severe disease. When we find the specific neurological complications associated with COVID-19 include the central nervous system symptoms like, I call it A, B, C, D, E, F. A for ataxia, B for actually the basic function of nose smell. C stands for coronary artery disease, that is presenting with stroke, and D for dizziness, and E for epilepsy, and F for fatigue and as well as pain. Peripheral nervous system includes hypoxia, hyposmia, and hypopsia, neuralgia, and skeletal muscle symptoms can be summed up in A to F. In the paper on Wuhan patients, 37 patients out of 214 displayed neurological complications, and 50% of those are with severe infections. Skeletal muscle injury was seen in almost 20% of the patients. Next slide. Next slide, please. The specific neurological complications linked with COVID-19 are, there is not an adequate data on the neurological aspects from our past experience with MERS and SARS. Some evidence suggested the presence of complications such as acute disseminated encephalomyelitis with possible demyelination, encephalitis, brainstem encephalitis in rare cases. Acute necrotizing hemorrhagic encephalopathy has been reported with other viral infections, and a case in the airline worker has been reported with COVID-19. Critical illness polyneuropathy, including Guillain-Barré syndrome, was also observed in some cases. Some studies have also suggested loss of smell or taste to be the clues to COVID-19 diseases, and the neurologist may pick up these signs during the examination. It is worth noting that this may be the only complications which may be occurring in the early part of the illness in some patients. Next slide. Specific neurological complications linked with COVID include some patients with particularly neurological conditions who receive certain treatments for neurological conditions, or who also have other non-neurological conditions or at increased risk of complications of COVID-19. Next slide. How can COVID interfere with the immune modulating therapy? Patients with diseases like multiple sclerosis are on immunomodulating therapy. However, therapies such as natalizumab and used in the treatment of multiple sclerosis or drugs that act to inhibit emigration of T cells into the CNS system are unlikely to increase the risk of COVID-19, because it is postulated that the COVID-19 does not cross the blood-brain barrier. It might act through the intravascular hematopoietic system or vascular conditions. It has to be noted now in future analysis of cases where Italy has got a separate unit for stroke unit can clear this doubt whether it can cross blood-brain barrier. It should be noted that serious cases of the fatal ones may be due to acute respiratory distress. This disease is particularly immunopathogenic, and hence pro-inflammatory cytokines or inflammatory cell infiltrates can actually be triggered by the infection and may be responsible for causing a component or the damage. It is worth noting here, there is no evidence-based medicine. The experts really have to look into the evidence base, but the experience of all the people all over the world, particularly from China, Italy, France, and US, should give us a clue about this whole episodes. Now, how can COVID-19 interfere with immune modulation? If it is known the antibody response is a criteria in protection against the COVID-19, the drugs that blunt most antibody responses should be avoided. On the contrary, if the T cell responses are critical, it is imperative to avoid drugs that have blunted the T cell responses. Unfortunately, there is not enough evidence. Current clinical trials are ongoing in USA and China assessing the therapies. Drugs inhibit pro-inflammatory cytokines IL-6 and sphingosine phosphate inhibitors among different populations of COVID-19 patients. In general, as a physician, we should be careful with people who are immunocompromised and may be at an increased risk of severe infections, especially cancer patients or hematopoietic cancer, or severe some patients from type in blood malignancies, lymphoma, etc. Next slide. The impact of COVID-19 on neurology practice ensures that elective procedures or admissions are postponed, such as epilepsy monitoring unit admissions. Engage in providing telehealth services, even though it's not clear whether the neurological syndromes are a direct cause of COVID-19 infection. It is important to look out for the acute neurological complications, especially in sick patients. There have been a large number of acute neurological patients testing positive for COVID-19, and hence important to be vigilant with such patients. Next slide. Treatment recommendation for prevention. Experts in neurological subspecialties have attempted to estimate the risk associated with COVID-19 from each neurological conditions or its treatment. It is very difficult to accurately assess the risk for every condition. The risk has been divided into 3 levels: low, moderate, and high. People with a neurological condition with a low or moderate risk might be considered high risk if they have additional risk associated with the conditions like lungs, heart, kidney, etc. Next slide. So in summary, of course, recommendations for prevention should include mothers can be breastfed their children. It's not passed through the fecal route at the present point of time, though 1 or 2 evidences are there. No evidence based on therapy available. Clinical experience based on therapy may be followed. Ibuprofen preferably be avoided. Hydrochloroquine and azithromycin should only be used in patients in ICU setting or healthcare workers or asymptomatic care patients likely to develop the symptoms. Tea and coffee 3 times a day may be beneficial in the original description of one study, where he says that the 3 components of which are present in tea might be very helpful in COVID patients. Next slide. Social distancing should be the only recommended for all people with all neurological conditions, their caregivers and family. Social isolation should only be recommended for people in the high risk category. Self-isolation is very, very important, whereas the social distancing is extremely necessary. Both of them really carry through our periods. And hence, when you look through, really what I wanted to say was, if you look the whole system, especially in 10 points, I will just want to mention that you must be very careful in especially the neurological manifestations that are usually seen in patients with COVID. It's very, very easy, and you must be very, very careful that social distancing alone, you will get it properly. I just want to finish my talk by giving 10 points for practice pulse. Infectivity is greater, mortality is lesser when controlled with the general population. You have noticed literally neurological symptoms. I want to have the alphabets remembered. A for ataxia and arteriosclerotic encephalopathy. B stands for basic cranial nerve dysfunction like first cranial nerve, 5th and 9th and 10th. C stands for confusion, especially in the morning with cerebrovascular accident. D stands for dizziness. E for epilepsy. F for fatigue and pain. The course of the disease usually from China. They say, according to Zhong, it may be over by June. According to Adam, it may take 1 year. According to Neil Ferguson, till a vaccine is instituted, it may run a very slow course of 18 months. Vanderbilt said, just like in all the other viral infections, it may settle into a seasonal disease like cold and cough. The mortality, we have to calculate only according to the case fatality rate versus the infective fatality rate. We are having a very long distance for that. And if you notice, the patients who are dying due to COVID-19 have a period of 6 to 41 days as per the literature, but the maximum is 80% is more than 60, 75% is definitely with other etiology and comorbid conditions. Mortality depends on A, the volume of testing of the patients, quality of the healthcare system available, treatment options, time from the units to the respiratory crisis symptom starting, and age, sex, and health status of the individuals. All of them contribute to the mortality. This mortality of CFR and IFR will decide in future what to go about it. In spite of this, a sudden death has been reported in about 7 days. On the 7th day in the respiratory failure, if especially respiratory people put on the respirator, you must take one precaution. When a person crosses the 7th day and dies suddenly, then only you think, then also you can think of COVID-1. So put it in nutshell, the 10-point presentation for prevention. Number 1, hand washing. Number 2, surface cleaning. Number 3, face mask. Number 4, respiratory hygiene. Number 5, social distancing, which is more important. Self-isolation if symptoms are present. And then, of course, you have to have the medications and, if possible, immunotherapy. And finally, of course, you have to go for physiotherapy. I think neurology, I always say the treatment etiquette is most important: to cure sometimes, to relieve often, and to comfort always. And then by social distancing, you can definitely beat this neurological problem. Identify early, treat early, start early, give them a very good health. Thank you very much for giving me the opportunity to speak to all of you and give my thoughts on this aspect. Thank you very much.
Thank you, Dr. Srinivasan. The key message is loss of taste and smell should be taken very seriously while history begins. This may indicate infection with the COVID-19. And immunocompromised people must take precautions, and they should preferably, as advised, they should be on prophylactic, some kind of a like hydroxychloroquine or like that. And something new you have said, tea and coffee 3 to 4 times a day, maybe some beneficial. Good.
Exactly.
Thank you very much.
Sure.
Thank you. Thank you, Srinivasan. Now.
Thank you very much. Thank you very much for your.
Okay. Please.
Thank you.
Yeah.
Bye.
Can leave the room, please. Thank you.
Thank you. Thanks a lot.
Thank you. Thank you.
Bye.